Okay, good morning. This is the second part of and the final lecture of this preparation material for the 10th edition of advanced course in mechanical ventilation that we want to sum up all the important concepts about protective ventilation in the OR. In this part, we are going to go through the tidal volume, the amount of tidal volume. Because as you know, I think there is no one who are supporting still using a huge amount of tidal volume or what is called large tidal volumes or tidal volumes higher than 8, 9 meters per kilo. Nobody. Nowadays, you can find different approaches about protective ventilation. But I support, I think the only thing that we all have in common, and I mean all the key leaders' opinion about protective ventilation, mechanical ventilation, all of them are always supporting to reduce the tidal volume. But the story is say, okay, everybody said we have to reduce tidal volume, but nobody do it. So I think there's a question, say why people are not reduction in their practice tidal volume. And I think it's the way we present the data again. If we go through visual things, through pulmonary physiology, probably clinicians are going to change their practice. In my opinion, this story is like we are not doing the right question. It's very simple in a lecture say, okay, you have to go for 6 meters per kilo and everything is solved. And it's not true. And if you try to do that, the patient go for hypercapnia. So clinicians realize in front of the patients and in front of the ventilators that what the key leaders' opinion that the papers and clinical randomized trials is saying really it doesn't work. And if it doesn't work, I don't trust it. So I go back to my routine and old practice. So let's just try to do in a different approach. I always make for these key leaders' opinion who say set 6 meters per kilo to everybody, and this must be done always, 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 always. I always say one thing. If I were a ventilator and someone programmed me with 6 meters per kilo, and I have to ventilate all of your lungs, imagine all the lungs of a big room with 1,000 people, do you think that all of them will respond with the same amount of pressure? The answer is no. So if it's no, because physiology is clear, you have physiology inside of you, we studied someday, but then I don't know why we in some way we lose it and we then change to numbers. And I think if you stop follow lung physiology, I can tell you this doesn't make any sense. So probably this story is there, but we have to present in a different way. What physiology can tell us about tidal volume. The first thing, and it's nice to know, neonates are programmed to receive 6 meters per kilo tidal volume, is the way they ventilate. And the second important thing is neonates cannot increase tidal volume. If they have more oxygen demand, the only thing they can do to increase minute volume is to increase respiratory rate. But they are not designed to have suspire or signs like adults. They cannot do a 12 meters per kilo breath. So neonates increase the minute volume through or increasing respiratory rate, never increasing tidal volume. Why I say that? Because we all know that the neonates is a special lungs. They are lungs who are not in the better conditions. The functional capacity is low. The surfactant is not perfectly well distributed. They have a huge amount of oxygen consumption, so they have to double. The oxygen consumption of a neonate is double or triple. So it's a very special model that you have in the physiology, and the only thing you have to do is to master neonate physiology, and then you understand how can we answer some question in adult in a specific situation. So another data. I love this paper. This is a very nice paper published in Nature in 1983. And he measured what was the physiologic tidal volume in all different species. And what is incredible is there is no significant difference between, for example, bat, mouse, rat, pig, dog, and man. Human beings are designed to have exactly the same tidal volume per kilo that most of the mammalians and most of animals. So what we can say through this paper is like whenever an animal have a lung, lungs are designed to receive a tidal volume is not low tidal volume, is physiological, is a physiologic tidal volume, and the physiologic tidal volume is around 6 meters per kilo, no matter the species have these lungs. Okay, another key point, I think really I considered this paper one of the keystone of protected ventilation. This was done in for ARDS net group, who showed to us for the very beginning that if you give a tidal volume of 12 meters per kilo, the mortality in distress syndrome was almost double. It was much higher than if you give only a tidal volume of 6 meters per kilo. The story about this paper, and this paper was crucial, and we all must know it, is the first to alarm us that we have to reduce tidal volume, at least in distress syndrome. But the story, and in my opinion, was the mistake that is being transmitted generation after generation and year to year from some key leaders' opinion saying, if you set 6 meters per kilo, everything is done. And this is not what this paper is saying. Imagine for one, just to think that this paper, instead to choose 6 meters per kilo comparing with 12 meters per kilo, imagine that this choose 5 meters per kilo and compare with 10 meters per kilo. Do you think that the results will be much different? The answer clearly through physiology and clinical common sense say no. Results should be exactly the same. So what the conclusion and the message from this paper is like if you reduce by half the tidal volume, so important amount, you create less damage. And this is no doubt about this. So the story is like a reducing tidal volume is necessary to reduce driving pressure, but not like a magic number. So probably 6 meters per kilo is not, it shouldn't be the same for all patients. Probably some patient with good lungs and anesthesia, healthy lungs, probably can receive higher tidal volume with no problems, and just the opposite, lungs in distress syndrome in a very bad situation, even with 6 meters per kilo, can have mad damage. Okay, so adapt the tidal volume to the real anatomical size of the lungs is probably one of the first advantage and keystones in protective ventilation. So the first great improvement in protective ventilation is try to reduce or adapt, not reduce, adapt the tidal volume to the anatomical size of the lungs. You can do it through this formula that is different for men and women. But this, at the same time, I always give one advice, and it's fixed quite well for your daily practice. If you, what we have to do is like the size of the lungs is related with the height of the patient. So the longer you are, the bigger your lungs are, and vice versa. So how can we set this? The way is that we can, for a man, if you get the height minus 100, this is the theoretical dynamic compliance. So it's telling you the size of these lungs. For example, my case, 186. So minus 100, my compliance should be around 86. So it means like it's quite big lungs. In women, is your height minus 110. So, for example, a lady of 160, the normal compliance of her lungs will be 50. So it means like it's almost half size like my lungs. So, and that give us a guide to know if I can use more or less minute volume. Okay, for example, I love these pictures. You can see in the left side patient is like me, 1 meter 86 centimeters, and as you can see, the tidal volume it should be around this, because we have to adapt not to the total weight. We have to adapt the tidal volume to the predicted body weight. See what's happened in women. In this case, the height is 167, and if I adjust the tidal volume to the total weight, I can create a huge amount of damage, because as you can see, the predicted body weight in this case is only 59. So we have to adapt the tidal volume not to the total weight of the patient, we have to adapt to the predicted body weight of this patient. Why is this so important? Because traditionally, remember, we start to try to protect the lungs through reduction of plateau pressure. And this is only part of the equation, a very small part of the equation. The second one was PEEP, and this is the huge problems about high PEEP, low PEEP, whatever. And now comes tidal volume. That's what we're talking about. Why? If you reduce tidal volume, immediately you reduce driving pressure. But why is so important driving pressure, and why is a keystone of concept in the world of protective ventilation? Because in only one pressure, you sum up all the influences of tidal volume at the same time, plateau pressure, PEEP, and compliance of the patient. So that's why it's so important to control driving pressure. And the way to measure is plateau pressure if we are working in volume control, or maximum pressure if we are working in pressure control, minus PEEP. And we always should be less than 15. So why driving pressure is so important? Because finally, driving pressure can be presented in a different way. It's not pressure, it's the tidal volume that we've been talking about, but according or adjusted with the functional size of the lungs. Driving pressure equals tidal volume divided by dynamic compliance. So it's telling you that if we adapt the tidal volume, not even to the predicted body weight, it's one step further in protective ventilation. If we adapt the tidal volume in order to reduce the driving pressure to less than 14, 15, better 14 of driving pressure, but as maximum, if we reduce the tidal volume until the driving pressure is lower than 14, then this tidal volume is adapted to the functional size of the lung. This was presented in this another keystone paper that really report to us. They study the mortality correlated between the three types of pressure. What this paper wants to find out is who is the bad guy of the movie who kills the good guy. They compare plateau pressure, PEEP, and driving pressure. And they do it, this is the mortality curve, and they compare in group of patients who have two pressure descent and the other different. In this first group, all of them have the same PEEP. So if mortality is correlated with PEEP, the mortality line should be totally horizontal, and it's not. In this group of patients, PEEP is the same, and driving pressure is increasing, and plateau pressure is increasing. So if the mortality line is increasing, means like the PEEP is not the bad guy can be plateau pressure or driving pressure. So in the second group of patients, they compare a group of patients who have all of them increasing plateau pressure and increasing in PEEP. And the only pressure who is constant is driving pressure. And as you can see here in mortality line is totally constant and horizontal. So it means like PEEP is not the bad guy, plateau pressure is not the bad guy. The really bad guy behind all this pressure is driving pressure. If we have any doubt, the third comparison is quite important, because we see that the plateau pressure is the same in all these patients. Driving pressure is going down, is decreasing, and plateau and PEEP is just the opposite, is increasing. So imagine if what is telling to us this third part of comparison is like PEEP is not only a damage problem for distress, it's even a protective factor. So if you increase PEEP, you reduce mortalities, because mortality curve is just the opposite. So if you have any doubt in this comparison, now is comparing driving pressure with in three different groups. to know what is the limit to admit for the lungs of driving pressure. It's clear like mortality is almost like a line. The more driving pressure you give, the more mortality you have. And the critical point seems to be beyond 15. If you are giving more than 15, see how mortality is increasing almost like a line. And no matter the tidal volume you give. For example, in this area, all of these patients have very high driving pressure, but some of them even receive only 5.7 of tidal volume. So according with the traditional approach, like give 6 meters of tidal volume of pretty body weight to everybody, everything is solved, the answer is no. If the consequences of tidal volume is a very high driving pressure, you still are damaging the lungs of the patient. And just the opposite. Whenever the driving pressure is very low, lower than 12, 13, even if you give a little more of 6, in this case 7.5, the driving pressure is low, there is no damage for the lungs. So as a consequence, we can say if we compare tidal only to measure tidal volume according to pretty body weight, measuring the consequences that is driving pressure, we can say like the reduction in tidal volume obviously is important. There's no doubt on that. In order to obtain a reduction in driving pressure, but it's not important by itself. And there is no magic number because it depends on the elasticity of the lungs. If you have a wonderful elasticity, you can receive more tidal volume by pretty body weight. That is not going to create any damage. Still, we don't have these numbers, but this is my physiological approach, just to have some guide. It's clear that in physiology, with you suspire or you signed, you make a great sign, sometimes you can reach a driving pressure of 9. So probably if you are working with a driving pressure less than 10, it's impossible to create any kind of damage in any kind of lungs. Between 10 and 14 depends on the type of the lungs. Probably in healthy, totally healthy, normal lungs is not a big deal, but in preterm baby, neonate, the distress syndrome, the less the better in this area. And of course, even in healthy lungs, if you are using more driving pressure more than 15 or more, it's clear that you are creating damage. It's a question of time. Okay, for the ones who still have any doubt, I love this research from Professor Gary Nieman. It was not designed for this. This is another find out I find out just looking at these videos once, another. But I love it because you see at the beginning he tried to create mechanical protective ventilation through limiting only the plateau pressure. In this is a microscope put in the surface of the lungs with a window in the thorax in a peak, and as you can, it's exactly the same area. Limiting the plateau pressure, in both cases 30, you can see that the effect, anatomical effect, are totally different. In this area with low PEEP and very high driving pressure, you are creating cyclic atelic trauma, cyclic overdistension in the areas who are all the time opened, and cyclic open-close phenomenon, cyclic atelic trauma. Even with a very high driving pressure, but with a little more of PEEP to stabilize some of alveoli, you see how you reduce cyclic overdistension and you reduce cyclic atelic trauma. So as conclusion for protected ventilation in the OR, we can say that driving pressure is the most important independent ventilation variable to avoid villi. Never use more than 15, no matter if it's healthy or damaged lung, probably in distress syndrome even less. And driving pressure in the acute respiratory syndrome, probably something between 10, 12, 13, 14 is quite high. So as a sum up, we can say that the 3 columns or pillars for intraoperative lung protected ventilation is like a 3-leg chair. You can make a chair with 3 legs or 100 legs. More than 3 legs are going to be stable. But when you are using only 3 of them, if you remove only one of those legs, immediately the chair fell down. Why? Because you need the 3 legs at the same time. I use these images to focus this concept. There are many papers saying recruit maneuvers versus no recruit maneuvers with high PEEP versus low PEEP versus intermediate tidal volume or whatever. There are 3 pillars or columns that should be always work together. And if you don't put these 3 legs together, you'll never ever find any benefit for any kind of protective ventilation. The first one is use recruit maneuvers. Why we use recruit maneuver after intubation in anesthesia? To be sure that the lungs are fully reopened. And second, in my opinion, the most important part is to really have the option to individualize the PEEP settings. So second, after this fully open homogeneous lung, we have to set the minimum PEEP to keep the lungs open. The minimum as possible, try to individualize to keep these lungs open. Finally, when everything is fixed, stable, then is the moment to reduce the driving pressure as maximum. How? To reduce the tidal volume to the minimum. In order to what? In order to have a driving pressure less than 13, but besides that, to obtain your objective, the clinical objective, to obtain an end-tidal CO2 adequate for this patient, around 40-45, never less than that. And more concept and what I say to the decaload, I mean the 10 more message to protective ventilation. We focus on the most important one for OR, but here I think we have all of them for any sites, yes, in intensive care or in the OR. PEEP must be programmed individually and after obtaining an open lung before. Protocol of no disconnection, no suction is not sense at all to reopen the lungs and then disconnect it 10 minutes later. Tidal volume of 6 doesn't guarantee to avoid villi. Watch out driving pressure, the less the better. Not fixed and constant air relation. That will be is another very important, nice point, but we are going to see it in the presential in the course. Individualize the oxygenation and the ventilation levels for this patient. Not all the patients have to receive the same level of oxygenation and ventilation. VO2, at least try to fight for less than 0.6, 0.7. Restricted fluid balance. Prone position always helps or sometimes helps. Induce hypothermia. And in the last final step, if mechanical ventilation cannot support the patient, you have to go for ECMO. And another important thing is not only the maneuver, it's the timing. Timing is crucial. It's a therapeutic window for all these tools. For example, recruit maneuvers. Recruit maneuvers probably are useful after intubation when you receive the patient, but probably in intensive care unit after 1 week when the lungs are totally destroyed and is starting to have fibrosis, recruit maneuver is not going to help you at all. And that's all. I hope you enjoy all this series of lectures, and I hope you really have all the basement and all the concepts just to follow our next edition or 10th edition of the expert course, the advanced course in mechanical ventilation, that it will take place in September 15th, 16th, and 17th of September. I will be this year through the COVID pandemic. We are going to do it live in streaming by webinars in 3 different days, and I hope you can join us. See you soon.